Hey my friends, in this video today, we are diving into one of the most epic, intense, and beautiful physiological battles in the human body. Alright, let's lock in. Definition of labor. Imagine the uterus is a closed fist, right? Inside that fist is the fetus, the placenta, and the membranes. Labor is the series of events, a chain reaction, that happens inside the genital organs. What's the goal? To expel the viable products of conception. That means the living fetus, the placenta, which is the life support, and the membranes, the bag of water, all of it, out of the womb, down through the vagina, and into the outside world. That whole process. That's labor. Now, here's a major key point. What if this happens too early? Before 37 completed weeks of pregnancy. We don't just call it early labor. We give it a specific name. Preterm labor. That's labor that kicks off before 37 weeks. Very dangerous, very important to recognize. But wait, there's another twist. What if the fetus is previable, meaning it's too early to survive outside the womb, but it's still alive? And it gets expelled. It goes through the same process, contractions, dilatation, descent, but everything is smaller, miniature. That's called mini labor. Yes, it's a real term. Same mechanics, just on a tiny scale. Now, I need you to memorize the characteristics of labor. Labor is defined by four things happening together. 1. Regular uterine contractions, the uterus squeezing on a rhythm. 2. Effacement, that's the cervix thinning out, like a turtleneck stretching. 3. Dilatation, the cervix opening up, measured in centimeters. 4. Fetal descent, the baby's head or presenting part moving down into the pelvis. If you don't have all four, be careful. Terminology check. A parturient is the patient, the mother, who is in labor. And parturition is just the fancy medical term for the process of giving birth. Don't confuse them. Now, here is the biggest mistake students make. Listen closely. Delivery is not the same as labor. Say that with me. Delivery is not the same as labor. Why? Delivery is specifically the expulsion or extraction of a viable fetus out of the womb. But get this, delivery can happen without labor. Example. An elective cesarean section. The baby is delivered through the abdomen, but the mother never went through true labor contractions. So delivery can be vaginal, spontaneous, or with help like forceps, vacuum, or abdominal, C-section. Labor is the process, delivery is the event. Keep them separate. Normal labor. Now, let's talk about the perfect scenario. The dream. Normal labor. The medical term is Eutocia. For a labor to be called normal, Eutocia, it must pass 5 strict criteria. If it fails even one, it is not normal labor. Here they are. Criterion number 1. Spontaneous in onset and at term. That means it starts on its own. No pitocin, no induction, and it happens between 37 and 42 weeks. Not preterm, not post-term. Criterion number 2. Vertex presentation. That means the baby is head down, chin tucked, facing the mother's back. The top of the head, the vertex, is coming first. Not breech but first, not transverse, sideways, not face. Vertex. Criterion number 3. Without undue prolongation. That means it's not taking too long. We have time limits. For a first-time mom, prolonged is greater than 20 hours. For a mom who's given birth before, greater than 14 hours. Normal labor progresses steadily. Criterion number 4. Natural termination with minimal aids. Minimal aids means maybe some emotional support, maybe a little amniotomy, breaking the water, but no major interventions like forceps, vacuum, or C-section. The body finishes the job naturally. Criterion number 5. Without any complications affecting the health of the mother and/or the baby. No excessive bleeding, no fetal distress, no infections, no tears that cause long-term problems. Everyone walks away healthy. If you check all 5 boxes, that's Eutocia. That's normal labor. Beautiful. Now, let's flip the coin. Abnormal labor, dystocia, any deviation. Here is the definition, and it's simple. Any deviation from the definition of normal labor is called abnormal labor. That means if you miss any of those 5 criteria we just listed, it's dystocia. Let me give you examples so you truly understand. Example 1. The labor starts spontaneously at term, but the baby is in breech presentation but first. That's a deviation from criterion number 2, vertex. That's abnormal labor. Dystocia. Example 2. The baby is in beautiful vertex presentation, but the mother develops pregnancy-induced hypertension or the baby shows signs of distress. Even though the presentation is good, now there's a complication affecting the health of mother, baby. That's a deviation from criterion number 5. That's abnormal labor. Example 3. The labor is going fine, but it becomes prolonged, beyond the time limits. That's a deviation from criterion number 3. Dystocia. So remember, dystocia isn't just baby in wrong position. It's any deviation, wrong presentation, complications, prolonged labor, need for major interventions, or onset problems. Got it? Good. Date of onset of labor. Alright, now a very practical question patients will ask you every single day. Doctor, when will I go into labor? And your honest answer. It is very much unpredictable. We cannot foretell the exact date. It varies from case to case. And here's the crazy part, it even varies in different pregnancies of the same individual. A woman's first baby might come at 39 weeks, her second at 41 weeks. Same woman, different labors. Now, we do have a formula. Nagel's formula, you know it, subtract 3 months from the first day of the last menstrual period, add 7 days. But listen carefully, that formula only gives a rough guide. It's not a promise. Here are the real-world statistics based on that expected date. I want you to remember these numbers because they are crucial. Only 4% of women start labor exactly on the expected date. Just 4%. 50% of women start labor within 1 week on either side of the expected date. So that's the biggest chunk. Half of all labors happen between 39 and 41 weeks basically. 80% of women start labor either 2 weeks earlier or 1 week later than the expected date. So 80% fall into that wider window. 10% of women go to 42 weeks exactly. That's post-term. And 4% go to 43 weeks or beyond. So when a patient is freaking out because she's 40 weeks and 2 days with no labor, tell her she's in the majority. Relax. But monitor closely. True labor pain versus false labor pain, the diagnosis. Finally, the most clinically useful part of this entire lecture. How do you tell true labor pain from false labor pain? Because patients come in all the time saying, I think I'm in labor. And you have to make the call. Let's start with true labor pain. There are 8 classic features. I'll run through them. 1. Painful uterine contractions at regular intervals. Not random. Regular. 2. Frequency increases gradually. Starts every 15 minutes, then 10, then 5, then 2. It's a pattern. 3. Intensity and duration increase progressively. The contractions get stronger and last longer 30 seconds, then 45, then 60. 4. Associated with show, that's the mucus plug with a little blood. Pinkish discharge. 5. Progressive effacement and dilatation of the cervix. This is the gold standard. On exam, the cervix is thinning and opening. No going backward. 6. Descent of the presenting part. The baby's head is moving down into the pelvis. 7. Formation of the bag of forewaters, that's the amniotic sac bulging through the cervix. 8. Not relieved by enema or sedatives. You can give a warm bath, an enema, or morphine, true labor pains keep going. Now contrast with false labor pain, sometimes called Braxton Hicks or prodromal labor. Here are the 5 features. 1. Dull in nature. Not the sharp, cramping, wave-like pain of true labor. Just a dull ache. 2. Confined to lower abdomen and groin. True labor often starts in the back and wraps around. False labor stays low and in the front groin area. 3. Not associated with hardening of the uterus. This is key. In false labor, the uterus doesn't become rock hard like a bowling ball during the contraction. It might tighten a little, but not the full hardening. 4. They have no other features of true labor. No show, no progressive dilatation, no descent, no bag of waters. 5. Usually relieved by enema or sedatives. This is your diagnostic test. If the patient walks around, takes a warm shower, has a bowel movement, enema, or takes a mild sedative, and the pain goes away, that's false labor. True labor doesn't care about any of that. If there's any doubt, do a cervical exam. A cervix that is changing, effacing and dilating, is true labor. A cervix that stays the same over 1 to 2 hours. False labor. And that, my friends, is your complete masterclass on the definition of labor, normal versus abnormal, the statistics of onset, and true versus false pain. You are now armed with the knowledge to handle this like a boss. Don't forget to like, subscribe, and hit that bell. Stay strong. See you in the next one.